Fantastic. Thank you. Ask our panelists to come up to the table and invite folks up to the microphones for questions. We have about 20, 25 minutes. Holly.
Hi, Holly Taylor, Johns Hopkins University. Thank you all. Those were all great presentations. And I'm going to ask a question that Director Menikoff didn't mention about whether there's any timeline for the NPRM. And secondarily, maybe if you could comment on whether among the key topics that were addressed in the ANPRM, whether there were some that were sort of, home runs, no one said anything about it, versus a lot of support, or those that are that remain the most contentious.
Is this working? Okay, so in terms of the timing of next steps in terms of an NPRM, it's just difficult to say. I mean, as most of you know, this is a complicated undertaking. It is a common rule. Hopefully, as I've said before, sooner rather than later, you'll be seeing the next step in this, but I'm wary of coming out and saying it will happen by X months or whatever else. It's just difficult to say. It is what it is. So in terms of the ANPRM and what aspects of it that were sort of clear home runs in terms of everybody loving them, I guess, and again, these are just my personal reactions. You could get a lot just from looking at our web pages where you have all the comments out there.
Yeah, I absolutely, and I
sure.
With 1,100 of them, it's hard to get a good
no,
general
I understand.
sense. So.
Yeah, I mean, one thing you can do is look at the major organizations, particularly if there's an area that you work in or something, because a lot of those are great comments, and some of them are themselves 50 or more pages, so they'll tell you a lot. I must admit I was a little surprised at how few of them actually were home runs, in the sense that lots of people didn't like them. And again, I'm relatively new to government, and I must admit you discover the challenges of doing things and coming up with solutions that most people even like, or majority of people like. I mean, I could pick and choose a few. So one part of it was eliminating the need or the default for needing for continuing review on expedited studies. My sense was that was one of the things that actually a lot of people agreed on. I'm not even sure whether SACARP agreed on that. Barbara Beer could comment on that at some point. But many other things, it really kind of was sort of, well, I guess sort of greater harmonization across the government, between agencies, that sort of stuff. I think people in general thought that would be a good thing. But again, the biggest surprise was probably on so many issues. There were people all over the place. And often you would have people saying, well, this is a great idea, but we don't like the way you're going about it, that sort of thing. So I think I'd leave it at that.
Thank you very much.
Sure.
There was just to add to that, my sense is that in the sort of public reactions to the ANPRM, there was quite a bit of status quo bias. We don't really like the way things are, but when we start to see the possibility of changes, we don't really like the idea of changing them either. And I can imagine that it's a difficult place for your office to be. Yeah.
Hi, Laura Cleveland, patient advocate. This is a very basic question, Jerry, but I want to know what the Office of OHRP does. Yesterday we had a lot of talk about plain language and patient-friendly consent forms. No use in consenting patients if they don't understand what they're reading. And what does OHRP do to ensure that patients understand what it is they're reading, and that we have patient-friendly forms that are accessible?
Okay, I mean, I'm certainly, we're totally in favor of patients having a better understanding of what they're getting into when they enroll in a clinical trial. In terms of our role in a nuts and bolts sense, we're somewhat limited in terms of what the system allows us to do. A lot of what we do is in terms of education, in terms of policy, I mean, even in terms of ANPRM. One of what many of us think is the most important aspect of the ANPRM was a proposal in terms of informed consent and saying, look, we are all recognizing that consent forms have reached a point where they're just getting longer, they have more boilerplate, and the result of a lot of this is that basically you end up burying a lot of the key details that a person should actually be thinking about when they enroll in a research study. And so one of the purposes of the ANPRM was to give us greater authority in terms of saying, we now have a system that basically is huge, and it's not easy even for a government office to sort of say, let's change things. The regulations are rather vague. So one of the purposes was, let's see what can we do to actually substantially improve consent forms so people actually understand them. So they're shorter, so that at a point, so they tell in the first page or two what a person really wants to say. And there's certainly doubts on our side that we could just sort of, I mean, we tell people this all the time, but this is not going to change the practices of pharma and whatever, lots of big industries out there that are sort of wedded to consent forms the way they are and may have a certain interest in keeping them that way. So again, bottom line, we're on board with exactly your goal. We try to educate people. We try to encourage change. In particular, we're trying to change the rules so that there would be greater authority to make a more radical change and say, let's go from 20-page consent forms to 3-page consent forms that push the boilerplate somewhere else and that are to the point on what's going to happen in this clinical trial, what should you be thinking about in terms of your own interest in enrolling.
Okay. And because I don't know what ANPRM is, and because this is a public forum, can you?
Okay, so this is what I was talking about before, the advance notice of proposed rulemaking in July of 2011. The Department of Health and Human Services, partnering with part of the White House, the Office of Science and Technology Policy, put out for consideration a number of possible changes in the regulations. They went out for public comment, and the government is now in the process of moving forward with the next steps, which would be an actual document that proposed specific wording changes in the regulations. And one of the proposed changes, or one of the changes under consideration, was specifically, can we do better in terms of consent forms? And again, thematically, very much in the direction exactly you're saying, acknowledging that the current system is problematic and could significantly be improved.
Deborah.
Yep, Deborah Collier, Patient Advocates in Research. And so I think the good news is that all of us in the room have the ultimate same goal, which is to get good information to people so that they can make a decision that's right for them. But having said that, and I don't think you guys were here yesterday, but it seems like the system is really regulatory focused rather than patient focused. And while I don't think that's anybody's particular fault, it just seems like what our regulations have been based on is a reaction to atrocities that have happened, which we need to protect people, there's no doubt about that, but how to move forward. And so I was I guess I don't understand, Jerry, some of the, it seems like something like a health learning system or different discussions that we could have about how do we actually protect people based on the way the system looks now and the way we might be able to change it if we were developing something in 2014. I don't understand how, or if there are other ways that you've thought of where doctors who are faced with several different possibilities, several different approved drugs, but we don't know what's actually the best way to do something. How can we get the evidence that we need, and how can we help the doctors and the patients understand a little bit more about what would be useful for a patient? Well, actually, I'd like to hear, the whole panel. I know that the learning healthcare system is one possibility, but I guess I'm interested in what might be other ways to do that with our present system as well.
Yeah, and let Ruth, but basically,
I don't have an alternative.
Yeah, these are certainly concerns on the part of the government, and that's why we went out there with the ANPRM, in addition to specific things we were suggesting in terms of changes, which, by the way, I would suggest many of those changes are actually, they're not, again, the government functions in certain ways. It does things through regulations. Just because you're doing something through regulations doesn't mean you can't be achieving the higher goal. In terms of one of the missions of my office, for example, is ethics. And we were just talking about informed consent. One of the changes in terms of what is out there for discussion is putting in the regulation saying what the consent form is supposed to do is giving people what the information that a reasonable person would want to know and would use in making a choice about being in a study or not being in a study, saying that there has to be appropriate detail in the consent form, things like that, which I think are exactly what you're talking about. But I'm happy to let Ruth.
I think we're talking about different things. I mean, I understood your question to be, what are alternatives to a learning healthcare system for generating the kind of evidence that we all want as patients in order to be able to get better healthcare and to be less uncertain about what decisions to make when we have difficult health decisions to make. Was that the force of your question? That's what I thought as well. I want to say one thing really, since I know this is in everything you say now is forever, right? Everything is captured and maintained forever. As much as we have been gratified, my colleagues and I, by the extent to which we have been at the center of a debate now about how to think about a new ethics framework for research going forward, it would be completely ridiculous to assume that the idea of a learning healthcare system comes from us. And I want to be very clear about that. The learning healthcare system is a very powerful notion that has been developed by very, very, very talented people in health policy over the past almost decade, if not with roots that go well before then. And the idea is to do something exactly as you described, to confront the fact that the way in which we attempt to generate new knowledge now, while incredibly important and while incredibly successful at giving us all kinds of wonderful new treatments and interventions and important advances in healthcare, has in many respects failed us in not being able to give us as much information as quickly as we need it in order to make really good decisions in the everyday experience of being a patient or a doctor. And that's the central problem that we're facing today that the learning healthcare system is intended to solve. There are many other large questions in healthcare and in public health, of course, but this is the problem that the learning healthcare system is intended to solve. Now, whether a fully realized learning healthcare system, one in which research and practice together are sort of simultaneously in real time integrated, can actually be implemented is one big question. Another is whether it will really realize the benefits it's intended to realize. And a third is whether it can be implemented and realized in a way that is ethically acceptable. Right? So those are the three pieces. And our work has been about the last. It has been about, are there ways to ethically go forward so that the rights and interests of patients are really protected and in fact made central if we're going to move to this learning healthcare system approach. But there are a lot of conditionals, a lot of ifs. You know, will the people who run healthcare systems see a value proposition in learning healthcare from the standpoint of their interests? Will the kinds of incredibly important work that Susan and others in the collaboratory and other structures that are attempting to demonstrate what large-scale projects could do, and then how they could be facilitated in learning healthcare. These are all big unanswered questions, but fingers crossed that we can make some progress.
So I want to note we have about 10 more minutes and 3 questions. I'll just ask people to keep questions and responses brief. Barbara.
Barbara Beer of Brigham Women's Hospital and Harvard Medical School. So actually, I was sort of happy to hear a fair amount of consensus between what Ruth and Jerry were talking about in terms of the, many trials. And the central tension, as I began to hear it, was around the definition of an interventional clinical trial. And maybe that's an oversimplification, but where the boundary of an interventional clinical trial begins and ends, I think is something we need to spend a little bit of time on. And I think you'd both agree that anything that's being tested that is not FDA approved, for instance, needs informed consent, full board review, no question. Then we back away from that to things that are, anything that is FDA approved but used off label. Maybe that's something we should talk about, or on label, and where there is really no evidence that one is better than the other. So I wonder if you two could sort of get into it a little bit more. Yeah.
So, Barbara, I guess I wouldn't have said it was, I didn't think it was a definition of what's an interventional clinical trial. It was more which of these trials need consent, and if you were going to need consent, perhaps a modified version, Ruth's notion of different ways.
You're
of
right.
getting
I stand
informed
corrected.
consent.
So
As to the set of layers that you were talking about in terms of something totally innovative, something off-label. So probably the biggest category of contention are, or certainly recently, things that are basically already out there. They're definitionally standard of care, whatever that means. Just because you have things that are standard of care doesn't mean there might not be differences between different aspects of a standard of care, and you may not even be starting out seriously suspecting that there are differences in terms of those risks. And so the question is, how do you determine which of those trials either don't need consent or would qualify for one of these variant versions of consent? And I think that is the difficult line drawing, and I still don't hear a particular consensus in terms of what you have to look at are particular types of trials and see, okay, well, what is actually happening here? What is acceptable to the public to the extent that we may be significantly changing the relationship between doctors and patients, and things that doctors can do without getting consent that in the current system, it would have been research and we clearly would have given the patient an option to say yes or no to this.
But we do that now in hospital systems. We restrict the formulary. We have clinical practice guidelines. You're not allowed to vary from them, blah, blah, blah. We've done a fair amount of restricting practice.
And those are done. Yeah.
Mm-hmm.
So my only point on all of this.
And that's not as research, and I get that.
Yeah, no, I understand that. So this gets back to the basic overlaying legal regime, which basically says with regard to doctor-patient encounters, there are certain rules requiring the institution to do stuff in the best interest of the patient. That rule does not apply in the research setting. So there are certain things that we allow institutions to do on the clinical side, and I fully agree with Ruth. We could have an interesting debate about how well our system does what it should do on the clinical side.
So
OHRP has nothing to do with that, and that's sort of.
So you said, I'm just going to try and focus your answer a little bit. You said that in many of these standards of care, the question is which trials should need consent or modified consent or could be waived, et cetera. What are the pieces that would go into that determination for you? And how would we go about that? What's the solution set and the path forward?
Okay, I mean, this is getting ahead of ourselves. I think we are in the middle of a discussion about this sort of thing, and clearly a lot of the discussion that was centered around support is part of this. That is a conversation that's currently occurring. I mean, one of the key aspects here relates to risk and kind of the notion that there can be risks in these things. They're not necessarily the risks of the unknown in terms of you haven't already given this to lots and lots of people, but there are still some unknown things in terms of the differences between like one version of standard care and another version of standard care. And just saying they're both standard care doesn't turn it into a minimal risk trial. And so how do you draw these lines? Again, I don't think that's been worked out yet. It is part of a conversation in place. Clearly, Ruth's whole proposal is part of that conversation.
Barbara, I feel like you're arguing this. I feel like I should channel you and just keep on going. So I'm not sure whether I should or.
Well,
do
we've
you have
been,
time,
we've
or
been
we have
granted a
two more
few extra
questions?
minutes of,
Oh, we've been granted. So a couple of thoughts. I think Susan said it very well when she said reasonable people are going to disagree and have disagreed for a very long time in some cases about some issues, and judgments have to be made and lines have to be drawn. But the process now, I think, is one of, I want to make sort of two sets of observations. One is one cluster of things that needs to be done, and we're trying to contribute to that, is to identify potential candidate criteria. And if we have more time, I can go back to the ones that we are working with. And then taking those candidate criteria out to stakeholders of all sorts. We're holding engagement sessions with patients, for example. We're hoping to do more. We've completed 2 very extensive ones after a series of pilot ones, patients of different backgrounds with different conditions, to try to get from them, to learn from them how they would think about these criteria or other criteria. What do they think makes sense in a context of appreciating what we don't know, what we need, and why it's important. So you have to explain the problem and help people come to see if they agree with the problem or disagree with the problem, and so on. And then seeing whether you can actually come up with guidance or guidelines that will allow those criteria as modified from what we learned from engagements with patients and hearing what matters to people. And all of us are patients at some point, if not continuously in our lives, what we think, what matters to us, how this would come through, and then seeing if you can take that and turn it into something that can provide some guidance. And there's always going to be a judgment. There'll be borderline cases, there'll be tougher cases, there'll be low-hanging fruit where it'll be obvious that it would fall into one bucket or the other. That's the way it always goes, right? The question is to rethink this thing. The other pathway, though, is to recognize that context matters. So what we can do today, right, under the current regulatory structures and in healthcare systems, which vary tremendously in terms of the extent to which, in fact, to use the terms we like, patients are engaged and know what's going on, the extent to which there's transparency, and most of all, the extent to which there's accountability. So one of the big problems, I think, that needs to be addressed, that hopefully learning healthcare systems will help us get there, but it's a problem in our own research, and the research we do in ethics, is we do wonderful research, and then the problem, even when the findings have tons of zeros behind them, right, and we're really, really confident, is actually getting practice to change in a way that makes healthcare better for people. And the same is true in public health. The conversation you had yesterday about the consent forms are too long, they take forever, nobody can understand them, it's like the terrible stuff on the internet, you just check I agree so you can buy your whatever it is you want to buy, your airline ticket. We've been talking about that for how long? Decades, right? We don't need any more evidence that that's bad. And yet we haven't, that it's bad, that patients don't understand, that it's no good, that it defeats the moral purpose of soliciting consent. We know this. We've known it for 20 years. What's changed? So it seems to me that one of the really key challenges, if we're going to ask patients to allow them to participate, to allow their data and to allow themselves to participate in the generation of new knowledge, we owe them the commitment to the translation of the knowledge that is worthy of action into action. Mm-hmm. And so what we can do without patients' express consent in the current environment is far more limited, right? I think because we don't deliver on the bargain, right? Than what we might be able to ethically do in a context in which what we contribute as patients actually has a better chance of making the world better, if not for them, than for the patients that come after.
Thank you.
thank you. All right, 2 very quick questions and responses. Chris.
Okay, I'll try to be. It's Chris Doherty from University of Chicago. As an IRB chair, I never have investigators who are challenged by the notion of IRB review for minimal risk research. Sails right through when consent is waived and waivable. The challenges are when IRB says we don't think consent can be waived here. And in the learning healthcare system, you talked about the need for, in an ideal world of complete transparency, where patients are walking down the hallways and they're getting that information, and that's readily available to them, both in the hallways, in the clinical encounters, on the street, in the parking lot, complete transparency. If you step foot in this institution, you should know that your data is going to get used, and you might even be randomized to interventions that you otherwise wouldn't receive. But disclosure is easy, and I may have missed it, and I apologize for not knowing the Hastings Center report. But what people are asking about is this need, and with all due respect to consent forms, of course, they're really good at disclosure too. And the 30 years has not been about the ability to disclose, it's been about the ability for subjects to understand. And what I didn't see is a discussion then about, in the learning healthcare environment, what is the threshold of sufficient understanding to say we can go forward? Because if you're not documenting disclosure on an individual level, but at a community level, does your learning healthcare environment then allow for saying, okay, we're going to patrol the hallways and we're going to stop somebody randomly and say, did you know that we're doing this study? Tell us what you know about it.
Yeah. No, it's a great question. And let me just underscore, so there's, again, less risk of confusion. There will, in whatever system we have, the one we have now or one we might aspire to where there is more systematic learning, there will be many activities, perhaps the bulk of activities, for which patients will get express disclosure, explanation of what's going on to them, and either a chance to opt out, or a streamlined disclosure and a chance to opt in, or the kind of detailed, hopefully better done, informed consent process of the sort that we use in research today. So you're asking for the kinds of activities that would not require any of these specific explanations to particular patients, and either giving them a meaningful chance to opt in or opt out, right? So it's maybe a whole bunch of, let's just call them observational studies, for example, or, I'm sorry, then I don't understand.
Well, because at least, as you explained it, you create, and what makes Jerry anxious and creates that entertaining tension between you two is
I'm glad it's entertaining.
And I apologize for being entertained by it, but it is the point. It's the point of all this, that what you described, at least theoretically, was there could be a study.
Oh, I'm coming to that.
That would be randomized with intervention.
Yeah, no, I'm coming to that.
That might be more than minimum, but would not require documentation.
I got it. So, no, I was coming to that. Let's call them observational studies, or some studies that involved randomization of the sort that it's determined by the process that I laid out only too briefly, would not require express notification to patients. So let's go with everybody's favorite example, which is switching antiseptic soaps in the ICU or the OR. You're going to have a randomized design. You're going to do this through a trial rather than the hospitals just decide they're going to go to the other soap. That would be a classic example of the sort of randomized interventional, do you consider it interventional or not, I don't know, but it's a randomized design that involves an intervention where I think I could make an ethically defensible case and in a learning healthcare system could go forward without expressly telling each patient that their ICU is now going to be randomized to one soap or another. And I don't think it's necessary that you have randomized checks to see that patients understand or even know that that trial is available. What you do need is being conducted. What you do need in that kind of setting is the transparency, so that if someone wants to know really easily what kinds of learning activities, what kind of research is going on in my hospital right now, which you can't do today, right? So let's be really clear. Some of what we're proposing actually addresses current ethical failures in the healthcare system. If I want to know today what research is going on at Johns Hopkins Hospital as a patient, it's not so easy to find out, right? It's not so easy to find out. And that is something that needs to be fixed. And in this kind of structure would take account of that kind of issue. So I know we're going over.
All right. I was told that my primary responsibility as moderator was to have some backup questions available in case there weren't any questions from the audience. That turned out not to be the case. So please join me in thanking the panelists for a terrific discussion.